Today we are going to review our sacrum, coccyx, and SI joint projections. And what you will see on your screen in front of you are our AP axial projections. And if you look to the left-hand corner, you've got coccyx, AP axial coccyx. Our right-hand corner, I'm going to put an S. This is for our AP axial sacrum. And the projection at the lower portion of your screen is going to be the AP Axial Si Joints. The best way to study these AP axial projections is, just like we're doing here today, is putting them all out in front of you and really getting to understand and know the differences because they all look somewhat similar. So putting them together and comparing the differences allows you to work your way through the process of eliminating which projection it is or is not. To get started, we're going to look at the coccyx, and we'll go through some quick anatomy here. Here is the coccyx that is projected right in the center of this pelvic brim. Look at the shape of this pelvic brim. It appears elongated because we are angling our tube. Remember, we're going to angle it caudal. Caudal means what? Well, it means tail. So an easy way to remember which way to angle your tube for these projections, coccyx and sacrum, is tail to tail. You angle caudal for your tailbone. Okay, so because we've angled the tube, though, the type of distortion we are seeing is shape distortion. And what we have actually done is foreshortened the sacrum so that we project this coccyx into the pelvic brim. When we do that, we foreshorten the sacrum to project our coccyx into the brim. We also make the brim appear elongated. Okay. The brim is important to evaluate because this is going to be how we look at rotation. Is the coccyx equidistant from its borders to the lateral margins of the pelvic brim? Another way to look for rotation is look at this median sacral crest, which is this area right here in the middle. Is it lined up with the pubis symphysis? In this case, it is not. I'm going to erase that line real quick. And also, if you look at the coccyx, is it aligned with the pubis symphysis? And again, it is not. And we have more space on this side from here to here than we do on this side. So there is some slight rotation, but it is so slight, and we do get a clear view of the coccyx, not superimposed by the pubis symphysis. Excuse me. So this would not be a repeatable error, this slight rotation. Now we talked about angulation briefly, that it was tail to tail, so we're angling caudal. But how do we know whether we gave it the right amount of angulation? Well, you should be able to see, we're still talking about the coccyx. There it is. Let me get my little pen. We should still be able to see some open joint spaces within the coccyx structure. That indicates that we have the correct angulation for this projection. If these appear closed, then we are looking at a problem of not enough angulation. So going back to anatomy, we have SI joints here and here. We have sacral foramina. Now, you're not going to see all of the sacral foramina like you do on an AP sacrum. You've got your obturator foramina. This bone right here are your pubis bones. Okay, and below them, right underneath here, are the ischial bones. Pubis symphysis, and between the two, this of course is sacrum. Where these X's are up top, you are looking at the wings or the body of the sacrum. We see slight top of the base of the sacrum, and these to the left and right of the SI joints are your ilium. And remember, that is ilium with an I, not an E. And E is for the intestines, two totally separate structures, so make sure that you spell it correctly. Okay, now we're going to take a look at the AP Axial Sacrum, which you will find to the right of your screen. Quickly going over some anatomy. What must be included on an Ap Axial Sacrum? It would be L5, which you will find here. Right underneath L5 it would be the L5S1 intervertebral joint space. You've got the base of your sacrum. These little projections protruding upward are your superior articular processes of the sacrum. Make sure that you're specific when identifying those because there are superior articular processes on all of the vertebrae, cervical, thoracic, and lumbar. Coming down from there, you've got your SI joints again, here and here. Right down the middle is the median sacral crest. Right here where these X's are, these are the bodies. The body of the sacrum, the ala of the sacrum, whichever you prefer. You have iliac crest up to the side, the ilium out here. This is the pelvic brim. Okay, but let's take a look at the sacral foramina. You have got these small circles up at the top. These look more round and are more P-shaped. Here's another one here and another one here. Then you also have these more elongated circles that are more almond shape. That's a good way to be able to tell the difference between which sacral foramina you're looking at. The P-shaped ones, P, are the posterior, so P for posterior and are P-shaped. These more elongated ones are the anterior sacral foramina, A for almond, A for anterior. So that's just a quick, clever way to know the difference between the anterior and posterior sacral foramina. You have 4 posterior as well as 4 anterior. Now what we don't see on this image that we should see and should be included on an acceptable Ap Axial Sacrum is the Pubis Symphysis. Excuse me, let me grab my pen. Pubis Symphysis, which be located down this way. Follow this down here, this down here. Okay, this would not be an acceptable image for diagnostic purposes because this pubis symphysis is not included. You need to be able to see the entire pelvic brim. And notice the shape of the pelvic brim in comparison to the coccyx. It is more squatty and flattened. You could say it has an appearance of being foreshortened. And actually it is being foreshortened because we angle cephalically. So it foreshortens that pelvic brim area and then forces the convex curvature of the sacrum, that shovel shape, to become more flattened out so that we can see all of the sacral foramina in their entirety. This pelvic brim is important because it also gives us an indication of rotation. Do we have equidistant sides from the lateral borders of the pelvic brim and the sacrum? Now the coccyx you will probably not be able to see because it will be superimposed or should be superimposed by the pubis symphysis. Of course you have your pubis bones here. We're not seeing those clearly in here, but we see them over here on the coccyx. Another thing that we are not seeing on here that helps with rotation, if we were to see the entire pelvic brim and pubis symphysis, we should see these little densities protruding upward from the pubis bones. And these are our ischial spines. You don't see them over here, nor do you see them on the SI joints, but we do have some images in the classroom that you can see. These ischial spines are also a good way to look for rotation. Is one higher than the other, lower than the other? Are they equidistant from the sacrum? The sacrum should fill this entire pelvic brim area. So how do we know that we've angled correctly? We've got the correct amount of angulation and we've angled the right way. Cephalically, well, we look at these sacral foramina. Do they appear open? And are they free of superimposition from the pubis symphysis? In this case, they are, but we've clipped some important anatomy, so we would need to redo this image. Plus, we're missing a marker. Don't know if we're looking at right or left here. Okay. Moving on to our SI joints. This, at the bottom of your screen, this projection here, is your Ap Axial SI joints. Now, you will see that again we have angled our two. So we are going to have some foreshortening. We do have foreshortening of these iliac crests as well as this pelvic brim here. And notice the different shape yet again on this AP axial from this pelvic brim and from the AP axial coccyx pelvic brim. It is even more squatty and closed. And if you look at the position of the sacrum, it does fill that pelvic brim, but it is now superimposed by the pubis symphysis. And this is what we want for AP Axial Si Joints. Okay, and a quick look at anatomy. We are looking at L5 here. Of course, the transverse processes of L5. I'm going to zoom in just a little bit if I can, so give me a second. Okay, here we go. L5 is transverse processes of L5. You have spinous processes, L4 and L5. You have the L5-S1 intravertebral disc space, pedicles of L5, and vertebral body. Now, if you come down here, you follow the base of this sacrum, and up here are our superior articular processes of the sacrum. In this sacrum, they are not as prominent as the other one. You follow that down, and now you're looking at your SI joints, which is the main area of interest. This portion of the sacrum, again, is the sacral wings or ala or body. Iliac crests, our ilium here. Sacrum comes down here, median sacral crest, Sacral Foramina, Pubis Symphysis, Obturator foramen. This bone up this way is the pubis, and the bone coming down this way is our ischium. We do not see the ischial spine in this because the pelvic brim is foreshortened. We have femoral heads, femoral neck, greater trochanter, sitting within the acetabulum. Okay, your basic pelvic anatomy, as you are all well aware. We also have psoas muscles, or the shadow of the psoas muscles here. Now, another thing you will notice in this image, there is some densities in here that is obscuring or superimposing the pubis symphysis as well as the sacrum. Good news is it is not covering our SI joints, so it is not in the main area of interest. But what you're looking at, as most of you are aware at this point, is fecal matter within the intestines. And a lot of times that will superimpose or obscure some of the anatomy. And so it's very important to ask your patients to use the restroom prior to performing the projections. All right, so now that we've talked about poop and everything else, let's move on and talk a little bit about how do we know if this is a good image or not. Did we position our patient correctly? Well, let's look at the spinous processes. Are they within midline? I see 1, 2, 3 right here. They look pretty much in midline to me. We also want to look at the symmetry of the wings. Oops, excuse me. Wings here. Are they equidistant from midline? Our SI joints, are they equidistant from the midline? And is the sacrum slightly superimposed by the pubis symphysis? And we are answering yes to all of these questions, so it looks like we have a passable image minus the fact that we've cut off our right marker. So that should wrap it up today for AP Axial Coccyx, which is this one, AP Axial Sacrum, and AP Axial Si Joints. We are going to look at lateral sacrum coccyx and oblique Si joints next. All right, here is our lateral sacrum and coccyx. We automatically know that this is not a passable image because we do not have our lead marker. But we also do not have, and what should always be included is L5, S1 intervertebral disc space, which is missing, and a little bit of the L5 vertebral body. Think of it a lot, it's almost like an L5 S1 spot projection. So we must include that for it to be an acceptable image. We've also cut off the top part of our sacrum, which would demonstrate the sacral promontory. And this area here is the sacral base. Looking more towards the posterior of the sacrum, we are looking at the median sacral crest. And remember, the sacrum has a convex curvature to it. It's shovel-shaped, so it turns around this way. You're seeing some arrows down here. This is indicative of a fractured tailbone, which is one reason why we would do this projection. Other anatomical structures that you would need to pay close attention to are these guys over here. They run this way, and here's the other one running this way. These are the greater sciatic notches, and these, if lined up, give us an indication that we have rotated the patient just perfectly so. Too much discrepancy between these or separation between these indicates too much rotation, therefore we would need to repeat the image. We are going to have a little bit of overlap due to magnification and OID, but so this would be acceptable. It's never going to line up just perfect. Okay, here's our coccyx down here. You've got the first segment, the second segment, here's the break. Okay, this is the apex of the coccyx, which is the very inferior tip, and then you have the base of the coccyx here. Okay, if we were to have included this sacral promontory up at the top, we may have gotten a good look at the femoral head sitting within the acetabulum, and that is another good indication or indicator of rotation or lack thereof. You're seeing this blackened area here. This is not pathology. It is not really anatomy. It is what we call a UBF, an unborn fart, fellows and friends, or simply gas in the intestines. Okay? So what do we really want to see? Well, we talked about seeing L5-S1 joint, the sacrum, the coccyx. We also want to see this median sacral crest within, it should be in profile, excuse me. Not much else to know other than this is a difficult area to penetrate. There's a lot of tissue, a lot of bone, there's gas, so it is really important that you collimate properly to reduce any scatter secondary radiation, which ultimately helps reduce patient dose, because you have to remember you're putting in a lot of radiation near sensitive areas of the body. Last but not least, we have our oblique Si joints, and although some people may find them confusing, I don't think they're really all that bad once you understand what you're looking at. So here we have a right marker. These are two separate projections in case you didn't figure that out. This is projection number 1, and this is projection number 2. You must always do a right and left Si joint oblique projection because it is a comparative study. And these are done in posterior oblique positions because of the way that the Si joints open. They open posteriorly at an angle of 30 degrees. So this R indicates that we're looking at right side Si joint because you always mark the side of interest when you're doing these projections. But if we're doing these posterior obliques, we're looking at upside Si joint, which means we are doing an LPO position. So the patient is LPO, which means we're looking at right-sided Si joints. Therefore, if we are looking at the left-sided Si joint, then this must be an RPO. Again, you're looking at upside joints. So RPO is for left Si joints, LPO is for right Si joints. In terms of distortion, that is going to distort our image a little bit because we're rotating our patient, which causes foreshortening of this ilium. If we have over-rotated our patient, this ilium or iliac crest will become even more foreshortened in appearance, and this SI joint will be closed. If we have under-rotated our patient, you're going to have a much wider, flattened wing of your ilium like you would in a pelvis. As far as anatomy goes, we've already been through most of the anatomy here. These aren't the greatest images to look at. You have your right SI joints coming through here, your iliac crest, pelvic brim. This is the wing or ala of the sacrum here. Now remember, these are two separate projections, okay? So, and you've got L5 and L4 here. The sacrum is coming down along this way. If we were to see all of it, it's going to look curved like this. These little areas here are sacral foramina. And again, your median sacral crest. And that should do it, folks. If we have any questions, let's talk about them in class. These are great projections to start really understanding distortion. Remember, when you are angling a patient or angling the body part, you are causing foreshortening of an area. If you are angling the tube, you are causing elongation of a structure. And those are types of shape distortion. Size distortion is magnification. We can see slight magnification. We can't really see it, but we understand that it's there, and our job as technologists is to reduce the amount of magnification by keeping our part to IR distance small, therefore reducing magnification. Minification will only occur in digital processing. You will never see minification occur in film radiography, but basically we are shrinking an image down to fit onto a page or a piece of film through digital processing. All right, guys, until next time, have a good one.